I was like, I don't know who that is.
Hey everyone, my name is Doreen Stopchuk. I'm with the QIN-QIO. Thank you for the webinar, a practical and effective outpatient antibiotic stewardship initiative. Once the webinar begins in about a minute, I will mute all the lines for the duration of the presentation. Speakers, please press pound 6, unmute your individual line, and just wait 10 to 15 seconds for it to take effect. Okay, before we get started, I'm going to quickly review 2 housekeeping items. This call will be recorded for training purposes. Presentation is available on the event webpage, and the link has posted to the chat.
No, I don't at all. This is like just, it's okay.
We will take a few questions in chat at the end of the presentation if time allows. Excuse me, can you mute your line? We're getting background conversation. We encourage you to post questions using the chat feature. Please make sure to send your questions to all participants. If you need to ask a question over the phone, press pound 6 to unmute your individual line, or you can use your mute button on your phone if you have one. At this time, I'll pass this over to Amanda Gagnon with the New England QIN-QIO to get us started. Amanda?
Hi, everybody. If you can make sure your phone is muted, I'm hearing some background noise.
Okay, so
the leader has muted your line. To unmute your line, press pound 6.
So hi, everybody. Welcome to our presentation, a practical and effective outpatient antibiotic stewardship initiative. I'd like to just say it's important to note that today's speakers have no conflicts of interest to disclose. And now I would like to introduce our presenter, Dr. Venice Dennis. Dr. Dennis is a board-certified internist and the outpatient medical director at Mayo Regional Hospital in Dover-Foxcroft, Maine. She graduated magna cum laude with a Bachelor of Science degree in biology from the University of Wisconsin-Eau Claire in 1991, then went on to earn a master's degree in physician assistant studies at the University of Iowa in 1995, where she was recognized with academic distinction. Ms. Dennis practiced as a physician assistant in the rural Midwest for 5 years before furthering her education at the Chicago College of Osteopathic Medicine, where she earned a Doctor of Osteopathic Medicine degree in 2005. During medical school, she was a member of Sigma Phi, the Osteopathic Medical Student Honor Society. She completed her internal medicine residency at Bassett Healthcare, a Columbia University affiliate, in 2008, and then went on to join Mayo Regional Hospital later that year, first as a hospitalist. She transitioned to primary care internal medicine in 2011 and became the outpatient medical director in 2013. She currently has a part-time primary care internal medicine practice and sees patients at the Cancer Care of Maine Outreach Clinic in Dover-Foxcroft. She is the medical director for the Cardiac Rehabilitation and Community Mobile Health Program. She is also a member of the senior team and the Medical Executive Committee and chairs the Infection Control Committee. Her professional passions include innovative delivery of primary care, antibiotic stewardship, oncology, and caring for patients with substance use disorder. So I would love to welcome Dr. Dennis.
Can everybody hear me? Hi, it's Dr. Dennis. Can people hear me?
Yes, we can hear you, Dr. Dennis.
Okay, perfect. So thank you for that very lovely introduction. I forgot that if I included when I did what, that you would probably figure out my age, so that was kind of a bummer, but hey, that's okay. So welcome. I'm hopeful that I will be able to provide you with some useful information, hopefully teach you a few things, and give you something practical to take back to your own organizations. So we'll go ahead and get started with my slides. Maybe. So having trouble advancing my slides, if someone would be so kind to help me with that.
Dr. Dennis, you can use the arrows up above. Do you see the bar with your slide numbers? You can advance that way also.
Thank you. And there's a little thing on the side here that's allowing me to see every word I speak, so I'm going to try to make that go away because that's distracting. So I hope I will not lose you. Let's see here. Nope, I guess that's going to be the way it's going to be. All right, so let's go ahead and get started. So objectives, these should be familiar to folks who took a look at signing up for the webinar, so we won't spend any time there. Already has been stated that I have no disclosures. So I thought it would be reasonable to start with just defining the problem and reminding people what bronchitis is all about, because I think that can be a very useful place to start. So about 100 million people are seen in the outpatient setting per year and are given the diagnosis of given the diagnosis of bronchitis. So this accounts for about 10% of ambulatory care visits. So as you can imagine, if we can make an impact with this diagnosis, we could make a pretty good impact on trying to decrease the inappropriate use of antibiotics. So as a reminder, bronchitis is almost always viral, at least 90%, depending on what study you look at, it's up to the 94, 95% range. Despite this, if you go into clinics across our country, you have anywhere between a 50 and 90% chance of receiving an antibiotic prescription when your healthcare provider diagnoses you with bronchitis. So this is receiving, as one can imagine, both national and international attention, and groups such as the American College of Physicians and the American Academy of Pediatrics and Family Practice Docs and Infectious Disease Society of America are all kind of grouping together and saying, hey, how can we make some improvements here? So what is bronchitis? By definition, bronchitis is a cough that lasts at least 5 days. A couple things I think that are really important to point out. One is that the cough may or may not be productive. So folks may say, yes, I'm coughing up something, or it may be more of a dry cough. The sputum that people produce may be purulent, and I think that's a really good thing to highlight because sometimes even healthcare providers think, oh goodness, this person is reporting green or yellow sputum, and that must mean that there's a bacteria involved. The median day for coughing in a bronchitis illness is 18 days, which means that that means that 50% of people cough more than 18 days. So it's really important to educate our patients and tell them that they're probably going to cough up to 3 weeks, not uncommonly. Some people also feel well at the end of these 3 weeks, but still have this sort of naggy, prolonged, intermittent cough. It's very common and is thought to be due to bronchial hyperresponsiveness. Not uncommonly, bronchitis starts with more of an upper respiratory tract infection. So people come in with complaints of sore throat, runny nose, congested head, and then they report, geez, this has gone into my chest. Pretty classic presentation of bronchitis. A couple other things that are important to remember. Mild shortness of breath is not uncommon when folks have bronchitis, and when folks are being examined, not uncommon to hear rhonchi and wheezing on exam. So like I said, almost all of these infections are viral, and it's thought to be more of an inflammatory lower respiratory tract infection affecting the large airways, hence the rhonchi that we appreciate on exam. A couple of things to keep in mind. So it's not bronchitis when people have a significant fever. You can have some mild elevation in temperature, but a significant fever would not be common. People should not be breathing rapidly, be very short of breath, look sick, have mental status changes, or have rows on exam. Also, one thing that I think folks get a little bit mixed up in sometimes is that they say, this is a patient that has COPD, but they have now they have a bronchitis. That's really more an acute exacerbation of COPD, and quite possibly an antibiotic would be appropriate in that situation. A couple other things not to forget. One is pertussis. So pertussis is around. Oftentimes as healthcare providers and as healthcare consumers, we know that it's around. So if your patient comes in or you have symptoms consistent with more of a paroxysmal cough or whooping cough or post-tussive emesis, think about test for and treat for pertussis when that's applicable. Also, influenza. So people cough when they have influenza. So typically they have other symptoms like severe body aches, fever, et cetera, et cetera. Two other things that I think that are important to keep in mind. One is that there are multiple large, high-quality studies that do not demonstrate an increased rate of complications in patients who do not receive antibiotics when they're given the diagnosis of bronchitis. The other is we all want to make our patients happy, and we are concerned that perhaps they will be less happy with us if we don't prescribe an antibiotic. There was an interesting study in 2016 which showed that the physician's perception of the patient's desire rather than the patient's true desire for an antibiotic was actually more strongly associated with the patient receiving a prescription for an antibiotic. So let's talk a little bit about the potential risks of antibiotic overuse, and even just routine antibiotic use. So the number needed to harm in some studies is as low as 5. I've seen a range between about 5 and 24. So it's not uncommon for people to have minor and, unfortunately, some more major side effects from antibiotic use. So the typical things that come to mind are gastrointestinal, stomach upset, nausea, vomiting, diarrhea. Sometimes people develop a more mild rash, they feel headachy, women may develop a vaginal yeast infection. A couple other things to point out. Folks can have very serious allergic reactions to antibiotic exposure, and this would be anaphylaxis, which is life-threatening and which needs to be managed in an emergency department setting. Also have to talk, of course, about Clostridium difficile. So there are about 500,000 infections, Clostridium difficile infections in the United States per year, and about 29,000 people die of these infections. Not all antibiotics are created equally in this setting. Clindamycin tends to be a bad player, a little bit worse than cephalexin, and going down the line, quinolones, penicillin, sulfa, and macrolides. Brief mention about Stevens-Johnson syndrome, which thankfully is rare, but unfortunately has up to a 15% mortality. So very serious, desquamating illness as a result of antibiotic exposure, oftentimes a sulfa drug. And lastly, just a quick word about quinolones. So the updated black box warning in 2016, which probably many of us are familiar with, adding also tendinopathy and neurotoxicity to the black box. And unfortunately, some people are having difficulties recovering despite the fact that the antibiotic has been discontinued. So let's move on a little bit about healthcare costs. So just from the side effects, the more simple side effects, if you will. So there are about 140,000 emergency department visits in the United States per year due to side effects from antibiotics, and most of these are in people who are 19 and under. But it's also a leading medication class in the 20 to 64-year-old age group. And as we all know, with our lovely high deductible plans, as we're trying to navigate through our own healthcare system for ourselves, the median cost of an emergency department visit is about $1,200. Antibiotic resistance. So probably seems straightforward, but using antibiotics is the #1 contributor to this problem. It's estimated that there are about 2 million infections in the United States per year that are multi-drug resistant organisms. And the conservative estimate is this leads to about 23,000 deaths directly from the infection, but likely many more due to systemic complications of having one of these types of infections. As you can imagine, the cost of this is very significant. The direct healthcare costs are about $20 billion a year, and then the indirect healthcare costs to society, lost productivity, et cetera, is about $35 billion per year. Okay, so in this context, I had been chewing on this idea about an antibiotic stewardship project for a couple of years when I went to a Maine Quality Counts meeting a couple of years ago when I was introduced to the Choosing Wisely campaign. So what I decided to do first is sort out how we were performing as an organization. So I did a chart review from January 1 to March 31, 2016, and took a look at all patients in the outpatient setting and in the emergency department that were seen for the diagnosis of bronchitis. And I took a look at how often people were receiving an antibiotic prescription at the end of that visit. And I guess the glass half full is that we are consistent with not so great performance with the rest of the nation, but that's also the glass half empty. So we really had a significant opportunity for improvement. So what I did was I gave the Choosing Wisely ABIM folks a call, and I asked for free stuff. And the free information I asked for was patient information. Choosing Wisely, if people are not familiar with it, produces a lot of really high-quality information for patients. So I asked for these 8x10 patient educational sheets, and I also asked for a larger poster for each of my 5 outpatient practices as well as the emergency department. And they were more than happy to give me this, and it was for free, which always helps to kind of grease the skids when you're asking other people for money. So I went to my senior team and I said, hey, this is how we're performing, and this is what I would like to do. What do you think? And very generously they said, go for it, and we will give you some money. So that's my quick summary around the start and ask for forgiveness later. So as far as communicating with my group or trying to generate some interest with my colleagues, I have 5 practices. There's some geographic, I'm in a central practice, but there are 5 practices and the emergency department. So I don't see these folks every day. Face-to-face, I see them every 2 months. So not my most favorite form of communication, but I started this out all via email. And then we had some pretty robust discussions at the primary care level to try to kind of get things moving, if you will. So what I decided to do was make a goodie bag, and they've been now dubbed a wellness bag. So what the physical bag is it's about an 8x10 bag. It's made of the material that the recyclable grocery bags are made out of. It's branded with my organization. And in the bag, there are things like tissues and hand sanitizer, cough drops. We have antimicrobial hand wipes, probably a little bottle of water. So just some comfort items for folks when they come in and have respiratory illnesses that do not require an antibiotic. Additionally, we tucked the patient information from Choosing Wisely into each of these bags. The cost was, depending, this year we made them a little bit more robust, but the cost is about $5 a bag, just so people can kind of keep that in mind. Though I think I've spoken with some creative colleagues in New Hampshire, and I think they've been able to pull it off a little bit more cost efficiently. So I touched on this already. I went to my senior team and said, hey, can I have some money? And they were wonderful, and they said yes. And my HR director, who also does marketing in our small organization, was really instrumental in marketing of this. So he put together a press release, and that ran in local papers. It actually got picked up in the Bangor paper, which is about a 45-minute drive from our practice location and where the tertiary care center is located in our region. We also put it on our website, et cetera. So the results were really quite amazing. So what I did was I did another chart review from January 1 to March 31 of the following year, so 2017. And I'd have to tell you that I worked the numbers hard a few times because I really could not believe the results that we were able to achieve in the outpatient setting. But lo and behold, I did not fudge this data. We made a tremendous improvement. It was interesting because one of my teammates ran the report through our electronic medical record for me, and at first she came to me and she said, you know what, you're not going to be happy, this looks really bad. But the way that she ran the report was all of the appropriate codes for acute bronchitis, and then was there an antibiotic prescribed in the course of that visit? Or excuse me, was there any medication prescribed within the course of that visit? So what I was seeing as I then did individual chart reviews is that people were prescribing more comfort medicines, but they were not prescribing antibiotics, which was super. The emergency department was performing better at baseline. They didn't have quite the results that the outpatient setting had, but they still demonstrated some improvement with this initiative. So my marketing director, again, did a follow-up press release, which was nice. I got a little bit of community interest and ended up giving a little talk to a women's group at one of the local churches, and then very funny, they wanted to give me a little money too, so it's really been, it's been energizing. Also, choosing wisely, got wind of what I was up to, and they asked if they could do a little segment in their e-letter. So this is a nice summary of the project if people are interested. So as I said, I was pretty astounded by the market improvement, and so I went to my group because this was clearly a team effort, and I said, you know, why did this work? Why did this work? And I got back a couple of themes. So one was people really liked the collaboration between the outpatient departments, the outpatient department and the emergency department. We as PCPs, and I know I'm assuming there are some other PCPs on the line, it's frustrating when your patient comes in to see you and then they're not happy that you did not give them an antibiotic. They go over to their local emergency room, or 2 days later they go and see one of your colleagues and they get an antibiotic. So everybody was really watching everybody else's back, which was very empowering for my colleagues. Some of my colleagues really liked the information from Choosing Wisely. They felt like it reiterated everything that they typically would try to speak with their patient about, but that perhaps it had a little bit more credibility because it was coming from Choosing Wisely. What else to talk about there? So the bags themselves. Some patients just really thought these were cool. And we live in, I'm quite certain that many of us practice in locations where patients have a hard time affording fairly simple things for comfort. So some patients just thought these were really, really neat. They also, I think, served as a visual cue for my colleagues. We all had a certain number of bags. They were parked in our office. So the things were kind of staring us in the face all the time as a kind of a nice reminder regarding antibiotic stewardship. So what next? So we just started our second year with the same initiative. This year the bags have a few more goodies in them. we, once again, I didn't get posters this year, but I once again got information from Choosing Wisely. So it's posted in the examination rooms as well as in the bags that the patients are receiving. And I am not exactly sure where this will continue going, but my thoughts have been, and I did encourage my colleagues to do this, to really expand this to any respiratory illness that does not require an antibiotic. So if folks come in with a sinusitis after a few days, or an upper respiratory tract infection, or a sore throat, or what have you, use this as a conversation starter with people. I'm anticipating also trying to do a bag that's a bit more specific for children. So perhaps include a thermometer, in the age 1 and up group, perhaps some honey, that sort of thing. So the unblinded data part. So I'm going to do another chart review after this 3-month period has completed, and I've decided to take a look not only at specifically the diagnosis of bronchitis, but also other diagnoses like URI and cough and sinusitis, et cetera, because, as one of my astute colleagues pointed out to me when I was discussing this with them, they asked, hey, are you worried at all about diagnosis shifting? So I think that is a possibility, meaning that people know that I'm watching them and that there is another chart review and that this year they're going to receive unblinded data. So if they are being creative and calling whatever the illness is something besides bronchitis, and then sort of sneaking an antibiotic into in the patient's hand, then that might not hit my radar, if you will. So I am going to informally take a look to see if diagnosis shifting has been a phenomenon at all. And that is my last slide, but my last slide doesn't seem to want to come for me. So if someone would be so kind to, oh, there we go. So that is myself and a couple of my administrative colleagues with the Choosing Wisely poster, the little bags that we created, and the Choosing Wisely patient information.
Thank you, Dr. Dennis, for such an excellent presentation. At this time, we'll take a few questions. You can press pound 6 to unmute your own line and ask a question over the phone, or you can also enter questions in chat. But remember to send it to all participants. And to get this started, I have a question. So we realized that there was a big difference between the ER and the outpatient setting, the practices. Could you speak to that piece?
Yes. So I have some ideas, and I could be absolutely wrong, but my ideas are that I did not physically go and speak with the group about the initiative like I did with my own PCP group. I do have a little street cred over there because I started as a hospitalist and transitioned to the outpatient world, so I do know the 3 main ER providers. But during the time of this study, one of our 3 was away on military duty, so we had a lot of locum coverage. So I think that's probably part of the situation. I also thought, gosh, are people in the emergency department sicker? And I spoke with my colleague who's the inpatient medical director, and he said, you know what, everybody thinks their patients are sicker, but no, I don't think our patients are necessarily sicker. And when I did that particular chart review, if the diagnosis was COPD and bronchitis, I didn't dock people, so to speak, I took them out of the denominator because I don't really think that bronchitis was the diagnosis. It was really an acute exacerbation of COPD. So those are my thoughts. And like I said, I could be way off base, but those are my thoughts.
Thank you. I have a question from chat. Al Sandberg wants to know your definition of significant fever.
Oh, significant fever. Gosh, I don't know in my own head, what would I say? I would say if someone looks sick with a fever, I wouldn't make it a quantitative number. I would look at the patient and say, you look sick and you have a fever, and then I would be including other diagnoses in addition to the potential diagnosis of bronchitis. I know that's kind of a squishy, maybe a politician-like answer, but I don't really have a quantitative number in my head where I would say, oh goodness, this patient has a fever of 101.2, which means that this cannot be bronchitis. Hopefully that helps.
Thank you. As we wait for folks to pose their questions, I have one last question. Can you elaborate on your approach to extraction and chart review?
Sure. So my first chart, both chart reviews were done by the IT people that are in charge of our respective medical records. So they took all of the diagnoses associated with acute bronchitis, and they were able to get information about who received this diagnosis. The chart review for the ER was exactly the same both times, which was they were able to get the diagnosis and take a look at any medications that were prescribed within the course of that visit. For the outpatient setting, it got a little bit easier for me on the second go, because the first go was these are all the patients that were diagnosed with bronchitis. And what I had to do the first go round was actually get in every medical record, read the note, and see what happened in the course of that note. And I would have to say, as I was reading through, my colleagues were painting wonderful pictures for viral illnesses, and then you get to the end and rats, azithromycin, or whatever was prescribed. So the second go-round for the outpatient setting was as I had previously mentioned. So same diagnoses codes that we used, but this time she was able to query the system that generated a report. So any medication prescribed with in the course associated with that diagnosis. So I did go into and do some I went in and did some individual chart reviews as well, just to be sure that I trusted the data, because doctors are kind of funny like that. That was a little bit easier for me, so I didn't have to go into each and every chart like I had to do the first go round as we were getting to know how to run reports within our electronic medical records.
Thank you. So I'm sure you got feedback from your other providers. What would you say made this initiative a success?
Yeah, so I touched on this a little bit before. In the outpatient world, I think what came through loud and strong, or clear and strong, was that we all were on the same page. So people could confidently say, the care that I am providing for you today is the same care that you would get if you went into any of the practices and saw any of my colleagues. And they also felt pretty confident that the emergency department was on board as well. So people really talked about feeling empowered in this work. So I think that was probably the biggest success. The bags, again, some people thought they were, some colleagues and patients thought they were pretty darn cool. You know, you get free stuff at your doctor's office. Nobody gives anything away for free anymore. And the patient education, I think, was also a hit with my colleagues.
Thank you very much. One last question, and then I'll hand over to Amanda.
Sure.
What would you say was your biggest barrier?
My biggest barrier. Wow. You know, I'd have to say this went like crazy smooth. That's a great question. I'm really not identifying much in the way of barriers in the outpatient setting. I would have to say that my not seeing providers routinely is always tough, because I don't like to read a bunch of emails a day, and we're all busy in our practices and our lives, and my colleagues really don't like to have a whole bunch of emails. But So communication and the opportunity to communicate was probably my biggest challenge. And I would have to say, and now that I'm thinking about this, I didn't do a very good job getting to the emergency department for this next go-around either. So I think as an action item for myself, because we're just into month 1 of year 2, I'm going to try to get onto the emergency department meeting just so I can talk with them a little bit, educate them about some of the things that I've spoken about today to see if I can empower them as well as the initiative seem to empower my outpatient colleagues.
Thank you. So I have a question from chat.
Sure.
Ralph would like to know, what is your presumption for the anemic response of the inpatient versus the outpatient?
Yeah, so I think I touched on that. I think the presence of locums was probably the biggest thing, I think. Now, if I see the same response here too, and we have all of our usual guys in there, then clearly my theory is wrong. I think that there is probably some lack of, or some, I don't know if it's lack of understanding that's strong, but misunderstanding among many of us regarding the typical course of bronchitis. In the not so old days, I remember when I was a PA, I would make the diagnosis in the paper world of something like prolonged cough, URI with prolonged cough. Really what I was saying, and now that I'm smarter, I was saying bronchitis, and these folks were coming in maybe at week 2 and saying, gosh, I'm coughing and I'm sick and blah, blah, blah. But I think education, my ER guys did not hear this particular spiel that I've given you and my outpatient colleagues. So I'm thinking education, maybe not a whole lot of energy around this because it was primarily an outpatient initiative, and their perhaps perception that their patients are sicker, and then the presence of locum providers.
Okay. Thank you. I have another question from Dr. Philosoph from chat.
Sure.
He wants to know, did the organization allow you to be involved in this project full-time, away from patient care?
Gotcha. So the way I split my time now is I see patients the equivalent of 2.5 days per week, and then the rest of my time is administrative. So I did this in my administrative time. So I didn't not see patients to get this work done, but I understand that that's a pretty common challenge for many of my colleagues who are in full-time practice. And this doesn't have to be, it doesn't have to be a physician-led initiative. I know that there are many infection prevention folks on the line and other quality people. I think it's really getting the buy-in. One of my colleagues in New Hampshire, actually the way that she funded her project was to ask her colleagues to use money from their medical staff dues or from medical staff to do this. So that, I think that was really neat, and that helped, at least it was a show of significant buy-in. So again, I don't think this has to be very provider or physician intensive. It's really the communication and getting people on board, and recognizing that, at least in my little world, I've had very significant success.
Thank you very much, Dr. Dennis.
Sure.
Oh, there's another question. Could you identify the New Hampshire partnering institution?
Yes. So I'm horrible at names, but Julie is her first name. She's Frisbee Memorial, and I can certainly, whoever's asking, get a last name to them. She's in more of an urgent care setting, and she has done a very similar initiative. She has, the bags. She was the one that included the thermometers I had mentioned earlier. So that could be a nice contact. I think she would be more than happy to support people in that area, in that region.
Okay, thank you very much. At this point, if you can pass the ball to Amanda, and Amanda will take it from here.
Okay.
You're saying pass the ball to...
Let's see if I can figure out how to do that.
So, Dr.
Yes. I don't have my little ball on the screen anymore. It's probably because I did something silly.
You're asking the...
Dr. Dennis, you can just right-click on the ball.
Mm-hmm. I don't have a ball. That's my trouble. I just see my slide.
Oh, okay. I'm sorry.
That's okay. I had this strange...
Hello.
Go ahead.
Are you just seeing the slides in front of you?
I am.
Hit escape on your computer, on your keyboard, and see if that brings you back.
All right. So my slides are smaller, but I still have no ball.
Oh.
Maybe multimedia view. So, nope. When I'm in the multimedia viewer, it gives me all of the things that I have just said. I don't.
Okay,
have
Dr.
that.
Dennis.
Yeah.
Do you see the ball next to your name now?
I don't see my name. That's the problem. That whole piece of my screen has disappeared for me.
So if you see where it says panelist?
Ooh, found it. Okay, got it. All right.
Yep.
Found it. Thank you.
Okay, so right-click on the ball.
Yes.
And then drag it to Amanda, and then it will ask if you want to make her presenter. Click on yes.
Got it. Thank you. Sorry about that. That's okay. Clearly, people can tell that this is not my forte. I mean, the IT part of things.
Mine either, Dr. Dennis.
I have other talents, but not this.
So, hi everyone. My name's Amanda Gagnon, and I work with the New England QIN-QIO. So I just want, after learning of Dr. Dennis's super successful initiative to decrease antibiotic prescriptions in her practices and in the ER, the New England QIN-QIO, the main CDC and partners collaborated to create a similar wellness bag to what she had done for the state of Maine. So this initiative we created, it's free to participating sites who are interested, with the only ask being to collect some pre and post bag data, similar to what Dr. Dennis did in her practices. So Dr. Dennis was able to use the Choosing Wisely materials in her bags. We were lucky enough to have the New England QIN-QIO materials along with the Maine CDC and Choosing Wisely. So this document here, this is one of our patient-facing materials that my regional team and I created, and this is in the bag. So these were also endorsed by our regional PFAC, Patient and Family Advisory Council. So the bags also include, the main bags will include materials from the Maine CDC and Choosing Wisely as well. And also the physician talking point. So with the bags, we would be offering you an implementation guide for who's implementing the program, in a physician packet that includes physician-facing material. So this slide is an example of one of those documents, and this was created by the New England QIN-QIO regional team. So along with this, there's documents from the Maine CDC along with Choosing Wisely. And these are offered, even though my other 5 New England states that I work with within the New England QIN-QIO are not doing the bag initiative, these documents are available to all the other 5 New England states. And later on, I will give you the contact information for the state's contact on this Antibiotic Stewardship initiative. So now I'm going to introduce you to Jennifer Lau, who works with the Maine CDC. She's a pharmacist. She's their antibiotic-resistant coordinator. She has helped with creating these bags, and she's put together the implementation guide for the physicians. So I'll let her go ahead and speak to that, and then I'll take back over again.
Thanks, Amanda. So as Amanda mentioned, we created both patient and provider-facing materials to target patient education and empowerment regarding antimicrobial resistance and appropriate antibiotic use. But we also felt it would be important to support best practices and appropriate antibiotic prescribing amongst clinical staff, as these are the individuals that are the primary drivers of antibiotic prescribing in the outpatient setting. So in addition to the materials Amanda mentioned previously, the provider-facing materials include fun posters and window clings to decorate your facility with to your heart's content, provider pocket cards for common illnesses that present in the outpatient setting, so the URIs that Dr. Dennis mentioned, as well as UTIs and skin and soft tissue infections to support appropriate antibiotic prescribing. And this was in consideration of local resistance rates in the state of Maine. And these provider pocket cards were also vetted by physicians at the Maine CDC, the New England QIN-QIO, as well as Maine Quality Counts. And there are both treatment recommendations for pediatric and adult populations as well. And the implementation guide that Amanda mentioned, so basically this is a guide for antibiotic stewardship champions as well as providers. And it's divided into 4 basic sections. So the first one is making a commitment to antimicrobial stewardship. Second, ensuring clinicians are familiar with evidence-based treatment recommendations. Third, supporting patient education and empowerment. And fourth, monitoring trends and outcomes to assess impact and inform quality improvement. So we kind of break each of these steps down with more specific details. And we really try to address the behavioral and motivational challenges that are known to come up during stewardship efforts, and hope that our provider-facing materials assist in engaging staff at your facility. And that's about it. So let us know if you would be interested in receiving these materials.
So this slide has our contact information. If you are interested in participating in this initiative or finding out more, you can give us a call or you can give us an email, but we're here to answer your questions. And I wanted to mention, for those pharmacists who are claiming continuing education credit for this webinar, the ACP code is antibiotic. So you'll be able to enter that information when you complete the session evaluation. Others who complete the evaluation will receive a certificate of attendance. And like I had said previously, here's our regional contact information for the other states that are interested in receiving some of our documents that we have created for antibiotic stewardship. And I also wanted to point out that we provide, the New England QIN-QIO provides a learning center. So the Learning Center is our virtual learning system. It hosts free courses available to all healthcare providers. So as healthcare providers, we know that you're busy. You have very busy schedules, so courses are laid out in bite-sized chunks, and some even have continuing education credit. So, for example, you could take a pre-test and begin a lesson during a break. On the next day, you could continue the lesson as the system will ask you if you want to start where you left off. So it's also mobile-friendly, so you could begin a course at work on your computer and continue on your tablet or phone at home, or when you are out and about. So in order to keep things up to date and relevant, courses are reviewed by subject matter experts. We also welcome feedback from users. If it's a course topic that people want to see in the future, we have surveys in place to capture those requests. Providers can expect to see courses sorted by healthcare setting when they go in, but they are not restricted from any courses except our internal staff training. Managers can get reports on the courses their team are taking, number of times they're accessing it, their pre- and post-test responses and grades, and relevant feedback captured. So this can be helpful in identifying gaps or opportunities for reinforcement of training. So please visit the Learning Center at learningforquality.org and follow your healthcare setting instructions for creating a new account. If you have questions, please send an email to the email address listed on the slide. And then also you can connect with us on social media for alerts, news, and more. And now I'm going to pass the ball back to Doreen to close today's session. Thank you, everybody, for joining.
Just to add on, if any health center practices in Maine that are interested in taking part in this pilot, please reach out to Amanda. And also, as you said, the resources are available on our website, and so you can access it and feel free to pick from it. Thank you.
Hi, this is Doreen again. Thank you all for a great discussion. Again, please connect with us on Facebook or LinkedIn for the latest resources, webinars, and other offerings from the New England QIN-QIO. When you close out of this webinar, an evaluation will automatically appear on your computer. We will greatly appreciate it if you would complete this evaluation. And if you don't have time to complete the evaluation right now, or you're currently sharing the computer with someone else, you will receive an email tomorrow containing a link to the evaluation. As we mentioned at the beginning of the webinar, the PowerPoint presentation is currently posted on our website, and I did put the link to the presentation in chat. Within the next few business days, a recording and a transcript will also be added. The link for this will also be included in tomorrow's email. Thank you again for a great presentation and to everyone for attending. Have a wonderful day.